I welcome you all to this wonderful CME. Today I am going to teach you about the ultrasound guided approach to achieve neuraxial anesthesia, eFast and focus. Actually, we all know that the traditional approach to achieve neuraxial block is by palpating the surface landmark and tactile sensation, and it itself has high success rate. So the question arises, why do we need ultrasound assistance? There are cases when we face unanticipated technical difficulty, obese patient, edematous patient, a pregnant lady, or the patient with underlying spine deformity like kyphoscoliosis and ankylosing spondylitis, and patient underwent previous spine surgery. In such scenario, this ultrasound, which is very safe to use, helps us to delineate the difficult anatomy with ease, and the number of attempts can be reduced with high success rate. So before going into detail, I'll let you know what I'm going to teach. I'll tell you about the equipment, ultrasound machine, relevant anatomy and sonoanatomy, and then we'll move on to the procedure. So for achieving neuraxial block, we can use the technique in two ways. Either we can do a pre-procedural scan or we can do a dynamic scan. But this dynamic real-time scan is quite cumbersome and it has a long learning curve. And as of now, to achieve neuraxial block, most of the anesthetists, they are using pre-procedural scan. So be familiar with the equipment before you go for the procedure. The probe which you have to use is curvilinear probe. You can see here, the frequency of this probe is around 2 to 5 hertz. Switch to the examination type MSK, musculoskeletal, and if it is advanced machine, you can also find MSK spine mode. Then mode will be definitely two-dimensional, 2D mode. The depth which you have to set is around 6 to 10 centimeter, and your focus area will be 4 to 6 centimeter. Except in morbidly obese, it may increase. Then adjust the gain accordingly. You can scan the spine of a patient either in sitting position or in lateral position. I'll advise you as a beginner, always scan the spine in sitting position. So before moving on, we should know the anatomy of the vertebrae. When seen from behind, you can see these are the spinous processes. This is the lamina. These are the superior articular process, inferior articular process, and transverse process. The space between the spinous processes is interspinous space, and between the lamina are the interlaminar space. It is important to know all these things thoroughly. So coming on to the relevant sonoanatomy, as you all know that ultrasound beam cannot pass through the bony structures. The bony structure will appear as a hyperechoic white lines, and beneath it, since ultrasound beam cannot pass, there will be black acoustic shadow, that is anechoic shadowing. So we are concerned about two spaces. These space will provide a window to see the structure. These are the interlaminar space and interspinous space, which lies in between the lamina and between the spines. Now, while scanning, you should be also familiar with the two complexes, anterior complex and posterior complex. It is very important to know what is anterior complex and what is posterior complex. Posterior complex comprises of ligamentum flavum, posterior dura, and epidural space. It often appears as a single hyperechoic line, or maybe sometimes, if you are lucky enough, it can you can see it as a double line. The anterior complex comprises of anterior dura, posterior longitudinal line, and posterior part of the vertebral body. It is also visible as a single hyperechoic white line. So before moving on, we should know what views we are going to use to achieve a neuraxial block. There are two types of views, parasagittal views and transverse views. In parasagittal view, we will be scanning in three parts. We'll start from the midline around 3 to 4 centimeter away from the midline of the patient, and keep the probe, curvilinear probe, in longitudinal direction. And this view will be known as parasagittal transverse view. Slightly move your probe medially on the articular process. This will give you parasagittal articular view. Then again slightly move it medially with a slight oblique tilt towards the midline. Once you will tilt your probe towards the midline, it will provide you a window to peep between the interlaminar space. This view is known as parasagittal oblique interlaminar view. In transverse views, you have to keep your curvilinear probe transversely. First on the spine, palpate the spine. This is known as transverse spinous view. And once you will slide your probe either cranially or caudally in between two spine, it is known as transverse interlaminar view. So after being aware about the views, we will see in each view what we are actually going to visualize. So this is the parasagittal transverse process view. As I told you, keep your probe around 3 to 4 centimeter away from the midline in longitudinal plane. You will be able to see the blip of hyperechoic shadows. These are transverse process, followed by anechoic finger-like projections. So these resemble a trident. So transverse processes are seen like this, and this sign is known as trident sign. Now you slide your probe slightly medially, then you can see the articular process. That blip of hyperechoic line will change into continuous hyperechoic zigzag line. These resemble just like the camel hump. So once you move your probe to the articular processes, you can see these lines, and this is known as camel hump sign. Then slightly move more medially and tilt your probe towards medial side to form a parasagittal oblique interlaminar view. In this view, you can see these are the lamina, and there will be a break. Then lamina, then there will be break. This break is nothing. These are the interlaminar space, which will provide us a window to see the posterior complex and anterior complex. In between the posterior and anterior complex is the spinal canal. So now you are familiar with the sagittal view, what you will see. Now I'll move on to the transverse view. Transverse view are only two. Put your probe over the spine, then you can see this hyperechoic spinous process. Beneath it will be an anechoic shadow. Just adjacent to this, you can see one more hyperechoic blip. This is lamina. And if you will move your probe cranially or caudally, you will be able to see the interspinous space. In interspinous space, this is interspinous ligament. You can correspond with this. And these are the articular processes here. And these are the transverse processes. You can see it here. And what you are going to see here, this is the posterior complex and this is the anterior complex, and in between it is the spinal canal. So now we are aware of what we are going to see in longitudinal view or what we are going to see in the transverse view. To summarize and to tell you what is the importance of every view, let's go through it. Start your procedure in sitting or lateral decubitus, preferably in sitting position. Use a curvilinear probe with low frequency transducer about 2 to 5 megahertz. Adjust the screen depth to 6 to 11 centimeter, and then you can further adjust accordingly. The scanning is started in parasagittal transverse view, where you will visualize the trident sign. Slid your probe slightly medially in parasagittal articular process view. You can see the camel hump. Then tilt it, move it medially and tilt it to obtain a parasagittal interlaminar view, where you can see the sawtooth or horse head appearance. And you will be able to visualize the posterior complex, anterior complex, and thecal set. So why it is important? It is important to identify the interlaminar space in parasagittal interlaminar oblique view. How will it help you? It will help you that you can calculate the depth from the skin to the posterior complex. Like you can use a caliper on the ultrasound machine from the top of the imaging till the posterior complex. The depth you will know, how much your needle will go inside to attain a block. This is useful in paramedian approach also. And other things, what you can do, you can identify at what intervertebral level you are right now, have placed your curvilinear probe, and which is the best interlaminar space to approach. How can you know the level? Just put your curvilinear probe partly on the sacrum and partly on the transverse processes, and once move it medially in the parasagittal oblique view. That you can see a line of sacrum as a hyperechoic line, then an anechoic shadow, then the transverse process as a trident sign. That particular space will be L5S1. Just move your probe slightly cranial, then another space will be L4, L5. And similarly, you can proceed more cranially and mark your space. So it will help you to identify the intervertebral level. Now, once you have identified the intervertebral level, you can rotate your transducer in a transverse view and put your transducer transversely over the spinous process. This will help you to mark the midline. Just keep moving your probe on the spinous process and mark a vertical line to delineate the midline. Then you will keep your curvilinear probe in the interspinous space in between two spines, where you can just imagine if your probe is here and the interspinous space, you can identify the good interlaminar space which you should approach, mark a line, a horizontal line. The transaction of this vertical and horizontal line, with this transition vertical line has been achieved by the transverse view, and this horizontal line has been achieved by the interspinous view. Where they intersect, that will be the area where you have to put in your needle in the midline approach. And the depth you can see, like I showed you this diagram. In this interspinous view, you can measure the depth from the skin till the posterior complex. This is the depth, and now you have idea that which space you have to approach, what is the midline and what is the depth. This is how you achieve pre-procedural scan and achieve a neuraxial block with high success rate. Now let's move on to eFAST. eFAST is known as extended fast. As we will proceed and answer few questions, why do we need eFAST, what it is, and when do we need and how to do it. eFAST is nothing but extension of the fast. Conventionally, what we do, it was in a trauma patient to have a expeditious diagnosis. Ultrasound scanning is done in right upper quadrant, left upper quadrant, cardiac and pelvis region. However, in eFAST, anterior and lateral part of the chest is scanned. So eFAST is a non-invasive, safe, simple to use procedure as expeditiously at the point of care. It is highly sensitive and specific without any radiation, and it has essentially replaced the diagnostic peritoneal lavage. This basically not for eFAST, but it is mainly for FAST. So when do you do eFAST? You do it in the trauma patient. If the patient is hemodynamically unstable, by doing eFAST, you can do immediate intervention, life-saving interventions like putting ICD to drain pneumothorax or hemothorax. In hemodynamically stable patient, it will fast you for further diagnostic technique. How do you do it? In neuraxial anesthesia, you will be needing curvilinear probe, but however here you will be needing a linear probe with high frequency of 5 to 20 megahertz. You need a ultrasound gel and glove. How will you do? Patient is usually in spine as they are trauma patient, and operator will stand preferably on the right side, but any side can be preferred. Keep your ultrasound machine at ease so that you can manipulate the buttons with easily. And eFast, it is important to note, it should be completed in less than 5 minutes. So what we are going to scan? We are going to scan the anterior part of the chest and the lateral part of the chest. How you have to hold a probe? You have to hold a probe perpendicular to the ribs with the probe orientation marker pointing cephalad, okay, like this. And where to begin? Start at around third or fourth intercostal space in mid-clavicular line. In the mid-clavicular line at the third, fourth intercostal space. What you are going to evaluate? You are going to evaluate pleura to identify the pneumothorax or pneumothorax. Now here you can see these are the two signs. There are few signs which are normal. If I'll explain you this ultrasonographic image, you can see these are the ribs, and this is the pleural line. Below the pleural line, you can see shimmering grainy mixed echogenicity. It is this sign is known as ant on a log or lung sliding sign. This shows that the lung is normal. If this lung sliding sign is present, then the lungs are normal. Another normal thing which you can see are the A lines. You can see these lines. This is the pleura. These are the artifactual reflection of the pleura. Repeated horizontal lines. These are also normal. So what is abnormal? Abnormal is this. See, here you can see on the left side, lung sliding sign is present, A lines are present. On the right side, there is absence of lung sliding sign, though A line can still be visualized. So there is probability of pneumothorax, or in fact, I should say it is highly specific and sensitive. There is pneumothorax on the right side. Absence of lung sliding sign will show that there is pneumothorax. And further, you can confirm by switching over to the AM mode, which is a single dimensional mode. In AM mode, in normal views, you can see this is a normal lung. So initially, there will be horizontal straight lines, which will show no motion or chest wall waves. Below, you can see the granular mixed echogenicity. This shows positive motion lung. So this is this resembles a seashore. This is known as seashore sign. However, in case of pneumothorax, there will be no mixed granular echogenicity. Both the lines will be seen almost same, horizontal multiple lines, which resemble a barcode, and it is known as barcode sign. So you can see here there are few lines which are transient hyperechoic vertical lines which are extending from pleura to the bottom. These are B lines. These are abnormal, and this tell us that the lung is wet. Either there is pulmonary edema or could be inflammation. Here you can see this is fast scanning of right upper quadrant. This is liver. This is diaphragm. This is the collapsed lung. The anechoic area fully is pleural effusion. So you can even identify pleural effusion, which in case of trauma will be most likely pneumothorax. So now, after learning eFast, we will move on to POCUS. Over the last decade, it has been a very important, used as an important aid to the traditional examination. Why? Because it provides on-spot diagnosis, and we can do life-saving intervention with this point-of-care ultrasound examination. The area which we scan here usually are lung, heart, vascular, brain, abdomen, and musculoskeleton. In cardiac, we use following axes: parasternal long axis, since heart lies like this, parasternal long axis, parasternal short axis, and apical four-chamber view. Why do we use it? To rule out cases of hypovolemia, myocardial dysfunction, pericardial tamponade, pulmonary thromboembolism, sepsis, and we can also know what will this patient will respond to fluid, or is it safe to fill or not, through seeing IVC variability and heart condition. It is also used in cardiac arrest to identify the cause of pulseless electrical activity, to rule out massive MI, tension pneumothorax, and to differentiate between the asystole from fine ventricular fibrillation. and other aforementioned causes in the previous slide. EFAST we have already discussed. In vascular, it is used to rule out or diagnose deep vein thrombosis, abdominal aortic aneurysm, ruptured or unruptured. In neuro, it is helpful in measuring the ICP while examining the optical nerve sheath diameter to see the midline shift, extradural hemorrhage, and it is also used in the form of transcranial Doppler to see the cerebral perfusion pressure, subarachnoid hemorrhage, etc. It also has therapeutic uses. It can be used for vascular access to achieve central venous access, peripheral venous access, arterial access. It can be used to guide thoracocentesis or paracentesis or cardiocentesis, pericardiocentesis, drainage of other collections. It can be used as a guide in lung recruitment and positioning, and guiding decisions on bronchoscopy in the lung. Since I have short of time, I have just rushed through these three topics, but it will be sufficient for you for the exam. So finally, the take-home message is you have to be very thorough with the relevant anatomy and sonoanatomy before achieving your axial block. You should be always familiar with the equipment which you are going to use. You should know what position the patient should be, either in lateral, supine, or sitting. What are the views which you are going to scan? Always remember, eye sees what mind knows. So you should know what you are actually searching for. You just can't go and blindly try to find the diagnosis. You should have some probable diagnosis in your mind, then only this EFAST focus will help you. And your hard work and understanding will definitely save lives in future. I wish you all the best for the exam. Thank you.
Thank you, Dr. Namita, for such a detailed and lucid presentation. I hope we all are benefited by it, and especially PGs. And we can go on to the next speaker. Any questions?
No, ma'am, not till now. No questions.
She has presented so well that there are no questions.
Yeah, ma'am, there are no doubts.
No doubts.
Thank you so much, ma'am.